Well, good morning, everyone. I'm Ruby Nguyen. I'm faculty here in the Division of Epidemiology and Community Health. We're so glad to have you here. We're incredibly honored and excited to have Dr. Julia Joseph DiCaprio speak with us today about these highly important topics. Before we begin, I just want to tell you about the setup for our webinar today. We've set it up so that we can see one another, and then also that at the end of the presentation, Dr. Julia, which is what she goes by, Dr. Julia can take questions from an unmuted mic. So we're not so closed off. We like community here. We believe that community breeds better discussion. We ask that you mute during the presentation, and when you have a question at the end, we'll take raised hands and ask you to unmute to ask your question. You are always free to post questions into the chat box, and we can read those to Dr. Julia at the end. So once again, welcome to our seminar series. Dr. Diane Newmark-Steiner sends her regrets. She was unable to give the introduction today. I know that she is with us otherwise. So I'm going to go ahead and be the honored person to give the introduction for Dr. Julia Joseph DiCaprio. Dr. Joseph DiCaprio, again, she goes by Dr. Julia, is a pediatrician and adolescent medicine specialist. She currently serves as a senior vice president and chief medical officer of the nonprofit health plan UCare. Dr. Joseph DiCaprio leads UCare's clinical areas, which includes the newly established Equity and Inclusion Department. Dr. Julia is known as a results-focused healthcare executive who optimizes resources and energizes teams to deliver high-value care. She also continues to see patients monthly at North Point Health and Wellness Clinic. In these roles, Dr. Julia is responsible for setting and implementing a market-leading agenda for population health and clinical operations excellence for UCare's 500,000 members. She's a key member of the senior management team and provides strategic direction and operational oversight for UCare's health services division that includes equity and inclusion, medical directors, clinical services, mental health and substance use disorders, special needs and basic care, credentialing, appeals and grievances, quality management, population health, health services analytics, disease management, pharmacy, and ensures high quality, cost-effective care for their members. It makes me tired just reading it. Dr. Julia represents UCare in outside activities as local and national associations, work groups, and committees. For example, she co-chairs the Health Equity Committee of the Minnesota Council of Healthcare Plans and is vice chair of the National Alliance for Community Health Plans, the medical director group. Her extensive professional career in the Twin Cities includes 22 years at Hennepin County Medical Center, where she began as a pediatric and adolescent medicine specialist and advanced to several physician leadership roles, including chief of pediatrics. Dr. Julia has been a medical director for Medica, senior medical director of care management for Health East, and Fairview Health Services. Work with communities is a hallmark of Dr. Julia's career, and she serves on the boards of the Mental Health Resources and the University of Minnesota Physicians. She's a past board member of Planned Parenthood North Central States. Dr. Julia received a BS in physiology from McGill University in Montreal and an MD from the University of Illinois. And importantly, she received her Master's of Public Health in Maternal and Child Health from this division. So we are so honored and appreciative to welcome back one of our alumna. So welcome back, Dr. Julia.
Oh, you're so welcome, Dr. Nguyen. And you know, it's interesting, as you were talking about the areas that I lead here at UCare, even though I'm in my home in St. Paul, when I think about the areas or how I remember the areas is I have to go back to when I used to go in every day. I would walk around and say hello to people. And that's how I would remember all of the areas that I led, is the path that I would take as I was walking on the floor. Anyways, it is such a pleasure to be here with all of you virtually today from my home in St. Paul. And please allow me to thank the School of Public Health, Epidemiology and Community Health, and the Center for Anti-Racism Research for Health Equity, as well as Dr. Diane Newmark-Steiner, Dr. Ruby Wynn, Dr. Rachel Hardiman, and Barb Lux for inviting me and arranging for me to present today. You know, I was having dinner with a friend recently and told her about this presentation and that I planned to talk about my company, UCare, and its work to be anti-racist. Well, she works in higher education related to healthcare, but not in healthcare, and wondered why a health plan would want to commit to being anti-racist and what could a health plan actually do. In all candor, like individuals and other healthcare organizations, health plans are trying to figure out our role in advancing health and racial equity and our role in the larger anti-racism work. I believe, however, that a central motivation for most individuals and organizations is the understanding that healthcare needs to change. This was never more evident than during the past 2 years. So I'm looking forward to sharing my perspective on anti-racism and health and getting your feedback and thoughts. And I've left time at the end of the presentation for comments and questions. Well, as Dr. Wynn said in her very gracious introduction, I'm a pediatrician and an adolescent medicine specialist. I actually trained with Dr. Newmark Steiner. We were fellows together in adolescent health. Well, from the time I started working in healthcare, I was always interested in the context in which those patients I served, existed. So, how their health was affected by what we would now call the social drivers of health. Then I studied public health here at the University of Minnesota, and I became interested in the health of populations. And again, the context in which those populations existed. And over the years, my approach to care has evolved from where I started, which was trying to understand the lives of my patients outside of the clinic room, to understanding and addressing social drivers that might be impacting their health, to where I am now, which is understanding that unless we address the root causes of social drivers, there won't be sustained improvement in the health of those we serve. And those root causes are societal and structural. That is what I first heard Dr. Rishi Manchanda, and many of you probably have heard Dr. Manchanda speak. He's the CEO of Health Begins. Well, he described those root causes as community-wide social determinants and society-wide structural determinants of health, which includes structural racism. Like many companies in 2020, UCare committed to being an anti-racism company, perhaps without fully understanding what that meant. I mean, honestly, I think a lot of companies and leaders committed to that with a vague understanding of what that would mean and how they would operationalize that in their company. What UCare did know was that pre-pandemic, many UCare members faced barriers to health and wellness, and 2020 exacerbated them. So what we did have to do once we made that commitment was define what our anti-racism work would be. And it consists of 3 components with many subcomponents. First, we are advancing health and racial equity for our members, employees, and communities. For example, we're doing that by identifying and addressing health disparities as part of our population health approach. Second, we are evolving our diversity, equity, and inclusion initiatives. And third, we are identifying and dismantling systemic racism in our policies, procedures, and practices. And we are also looking for ways to include and amplify the voices of diverse communities in all of our work. So today I'm going to discuss how I, as a clinician and as an executive in a health plan, understands the impact of racism, the population health program at UCare, in which health and racial equity are core components, and UCare's current anti-racism approach. There's a framework that some colleagues and I put together based on other work that had been done that we put together to help other community-based health plans use as they consider health and racial equity initiatives. So I'll talk a little bit about that, as well as a framework that UCare's Equity and Inclusion Department is using. So I'll present those two frameworks, and perhaps you'll find them interesting in your anti-racism work, whether it's your own individual anti-racism work or work you're leading in your organization. So as some background, as was mentioned, I work for UCare. And as probably a lot of you know, UCare started out of the University of Minnesota's Department of Family Medicine and Community Health in 1984 as a Medicaid demonstration project. And over the years, UCare has grown and diversified. However, the cornerstone of our work is as a Medicaid health plan. This is important because we are highly regulated by Minnesota's Department of Human Services and the Federal Centers for Medicare and Medicaid Services, so DHS and CMS. By the way, I live in the land of acronyms, but I try hard not to either include them on my slides or use them in conversation. Anyway, CMS and DHS, they hold us accountable for the health of our members. And currently, UCare has, and it's grown, our membership has grown from greater than the 500,000 figure that Dr. Nguyen referenced. Unfortunately, we're happy to have those members, and unfortunately, it's a result of the pandemic. Anyways, currently we have 385,000 members through Minnesota's public healthcare programs, an additional 120,000 members who have Medicare Advantage, 20,000 members with Medicare Advantage dual eligible special needs plans, and 50,000 members who have individual and family coverage with us. Now, it's important for UCare as a community-based health plan to demonstrate our value to stakeholders, including our regulators, the Department of Human Services, and the Centers for Medicare and Medicaid Services. And historically, one way that UCare has demonstrated community benefit is through our work with communities, especially community-based organizations. So over the years, UCare has provided philanthropic support to counties through grants and some supported community health improvement through initiatives like a mobile dental clinic and a mobile food market. And philanthropy has historically been the way that most health plans not only demonstrated community benefit, but addressed social drivers of health. However, now UCare, like other health plans, is evolving how we serve members so that we are more rigorously advancing health and racial equity. And we're doing that primarily through identifying and addressing the social drivers of health that are impacting our members. And we use a population health framework that I'll speak more about in a bit. Our initiatives are often at the individual level, but occasionally they're at the community level as well. And the population health program at UCare, as well as levels of intervention, again, I'll talk about them later in the presentation. But for now, let me say that like most health plans, along with other healthcare organizations and public health organizations, we look for the root causes of inequity and look for ways to intervene. But I just want to say, and I referenced this earlier, we are at the beginning of understanding what it means to be anti-racist. Yes, we committed to it in 2020, but I wonder as the pandemic recedes and years pass from the murder of Mr. Floyd, will we again become inured to racist systems and structures and forget about that commitment and stop changing. But what I think is required is that we put in place processes and dismantle structures and systems so that what is put in place now sustains us past when far into the future after this moment passes. Let me just say, though, that I'll talk about the business imperative to be anti-racist. And again, I think that will sustain us into the future. However, I believe that more important than the business imperative or economic forces that are driving change, that the greatest reason to change is a moral one. I don't know a lot about philosophy or philosophers, but I've thought a lot about Dr. Don Berwick's 2020 Health Affairs viewpoint, the moral determinants of health, that begins with a reference to Immanuel Kant and the moral law within. What Dr. Berwick notes is that the research is clear on what is needed to improve health, but societies don't invest in those things. For example, shunting more of healthcare spending to what will prevent illness, such as addressing the high rates of incarceration or supporting elders suffering from loneliness, versus what we do, which is paying to repair the effects of the lack of investment and disinvestment in what is known to improve health. The special interest pressures that ensure the status quo are powerful. But what Dr. Berwick says is that a more powerful force would be if more of us, including those of us working and leading in healthcare, attended to the moral law within, advocating for what is right, even if it is not in our personal or organizational best interests. Nevertheless, there are economic and competitive pressures that are pushing for a different approach. And evidence that change is needed along these lines comes from the Minnesota Department of Health report to the Minnesota legislature, and the report is called Minnesota Healthcare Spending 2018 and 2019 Estimates and 10-year projections. This was published in October of 2021, and this report emphasized the need to address increasing healthcare spending. 2019 marked the third consecutive year of healthcare spending increases of more than 5%, reaching almost $57 billion. Hospital expenses, that's the largest spending category and accounted for 40% of the spending. Further, healthcare spending is expected to increase 6.9% a year and reach over $104 billion by 2029. Minnesota's economic growth, however, has not and is not expected to keep pace. So either spending must shift from other categories like education, or growth in healthcare spending must be curtailed. One recommendation from the report is that there be an assessment of how to provide, and this is from the report, a quote from the report, healthcare in a way that focuses on whole person health, whole person care rather, like public health and primary care, which improves health and does not substantially increase spending. That's the end of the quote. Additionally, health outcomes are not improving and disparities persist. In essence, we are not getting what we are paying for. So in order to deal with this unsustainable increase in healthcare spending, in 2019, the legislature and Governor Walz created the Minnesota Blue Ribbon Commission on Health and Human Services. And let me just pause and say, I'm referencing this not only to describe the economic pressures or competitive pressures, but actually the regulatory pressures on a company like UCare to do things differently and evolve. Anyways, the legislature and Governor Walz created the Minnesota Blue Ribbon Commission, on Health and Human Services to develop an action plan to advise and assist the legislature and governor in transforming the health and human services system to build greater efficiencies, savings, and better outcomes for Minnesotans. So further, the commission was tasked with finding $100 million in savings for the next biennium, and the savings were not to negatively impact eligibility or access. Plus, the other aims of the commission included looking for cost savings, administrative simplification, reducing waste, system transformation, and health equity. Unfortunately, the work of the commission was interrupted by the pandemic, but 22 strategies were presented in its report. This was a 2020 report, including 3 related to health equity. Those 3 were to improve dental services, ensure equitable access to aging and disability service programs, and redesign targeted case management to reduce disparities in medical, behavioral, social services, or supports. Further, the commission noted that the pandemic and the murder of George Floyd led them to put forward a vision. And this is how they described their vision: a vision of a transformed Minnesota health and human services system that provides fair and just opportunity for health and well-being, and where race no longer determines health outcome. So considering total state of Minnesota health and human services spending, $100 million is only a small amount, but the message is clear that a Minnesota Medicaid health plan like UCare has to, in order to continue in the program, and this is what we interpreted all of these findings as, that in order to continue in the program, we had to demonstrate new approaches to addressing health expenses while improving the experience of care, including quality, that the health of the populations that we served was improved, that the work we did wasn't on the backs of providers, and that we were advancing health equity. We see that as our imperative. Let me go on to say that health equity now is a cornerstone of work for most healthcare organizations. And of course, that's not surprising, because in addition to the costs of healthcare overall, the costs of racial disparities are clear. There's a moral cost, which, as I referenced earlier, is a more impactful cost than the economic cost. But the economic costs to racial disparities are clear. Laviste and colleagues found that from 2003 to 2006, eliminating racial and ethnic disparities in the United States would have reduced direct medical expenses by $230 billion and indirect costs by more than $1 trillion. Doctors Nanny, Allen, and colleagues here at the University of Minnesota found that in Minnesota, if racial disparities in preventable deaths were eliminated, up to 812 lives and up to $2.9 billion would be saved annually. And let me go on talking about costs by noting, as most of you know and are probably researching or have researched, that the impact of health disparities, those impacts have been compounded by the pandemic. And in 2020, has been widely reported, and you can see in this graph, life expectancy in the United States fell by a year. But the drop was 3 years for Hispanic populations and 2.9 years for Black people. The pandemic has starkly revealed the impact of racism on health. However, the impact of racism on health has been known for decades, actually over a century. Personally, as I mentioned, I evolved in my understanding and I knew the role of social drivers on health, but I'm embarrassed to say I didn't know as much about the impact of racism on health. And so a few years back, when I was discussing racism with my son, asking him more about it because I was hearing a lot about it, and I asked him about those structure systems that advantage one group or disadvantage another. I kept thinking about how I had conceptualized racism, which was that I knew a lot of racists. I had encountered them in my career. But what I had to do was, when thinking about the impact of racism on health, is develop a deeper understanding. Yearby, Clark, and Figueroa wrote, and this is how I'm now understanding the impact of racism versus racist, that a characteristic of racism is that its structure and ideology can persist in governmental and institutional policies in the absence of individual actors who are explicitly racially prejudiced. And as Dr. Nathan Chomolo, Minnesota's medical director for Medicaid and Minnesota Care, and our state's COVID-19 vaccine equity director wrote in the Minnesota Department of Human Services report, Building Racial Equity into the Walls of Minnesota Medicaid, a focus on US-born Black Minnesotans, that was published in February of this year. Dr. Chomolo wrote, racial health disparities result from centuries of policies that have structured opportunity along the lines of race in Minnesota. So much has been written about racism in health. And again, as it's been written for centuries, decades, and in fact, over a century. Dr. Hardiman and co-authors wrote in Health Affairs this year that in 1899, Dr. E.B. Du Bois pushed for systematic empirical investigation of societal factors contributing to racialized health risk and health inequities. And in 1996, Dr. David Williams noted in Ethnicity and Disease that, quote, given the centrality of racism to large social structures and processes, there are multiple ways in which racism can affect health status. However, the profound impact is at the level of societal institutions. So thinking about, and excuse me, this looks a little blurry to me, but thinking about what's occurring at the societal, systemic, or structural level, what is of particular interest to me because of the industry in which I work is the review article, Structural Racism in Historical and Modern U.S. Healthcare Policy by Yearby, Clark, and Figueroa. They explain the structural racism in healthcare coverage, financing, and quality. And one example they cite is that structural racism is also evident in some states' attempts to impose additional eligibility restrictions on Medicaid expansion populations, especially recent work reporting requirements. And what this slide has on it, which you may not be able to see because it's blurry, again, my apologies. As this review by Guth, Artiga, and Pham shows, there have been many studies that find that after Medicaid expansion, racial and ethnic disparities decreased. However, despite positive impacts of Medicaid expansion, Yearby and colleagues say that requirements have been defended as necessary to encourage work among the able bodies, that's a term often used, poor, reflecting assumptions that the poor must be coerced to work as a condition of insurance. These assumptions have historical roots in racist beliefs that Black people are lazy and have a poor work ethic. And that's heard today, European colleagues say, when lawmakers emphasize the urban poor, which many understand to be a reference or code for inner city Black people as the targets for these requirements. This is a quote from Dr. Yerby and colleagues' article. And so Seema Verma, who is the previous CMS, Centers for Medicare and Medicaid Services, administrator in the Trump administration, said that the goal of programs was to help improve the health of able-bodied Medicaid beneficiaries. She said, we saw the data that people engaged in work have better outcomes. When we talk about social determinants, she said, just giving somebody a Medicaid card isn't going to solve their problems. What she failed to say was that most people on Medicaid work, and those who are not working have significant obligations, such as taking care of family members, including children, and taking care of their own disability. I recently spoke with Dr. Jennifer Lee, who was the Virginia Medicaid director when they expanded Medicaid. And she shared with me how challenging it was getting support for expansion without including a work requirement. I don't believe that's been implemented, the work requirement in Virginia. And Virginia lawmakers are still complaining about the lack of a work requirement. So what can a health plan do? Well, I worked with colleagues at one of our national trade organizations, the Alliance of Community Health Plans, ACHP, Alliance of Community Health Plans, to put together a framework for advancing health equity that recognizes that health inequities are due to a complex web of social and structural issues. We suggested that health plans identify at least one equity issue to fully address and then use data and analytics to identify the root cause. Let me just pause and say this framework is not unique to the Alliance of Community Health Plan. It draws from lots of other research, but it was helpful for health plans that were not familiar with the literature to figure out how they might want to move forward and advance the work in their organizations. Anyways, we suggested that health plans develop solutions that act at the individual, community, and systemic levels because of the complex web that links these issues. At the individual level, we suggested that health plans work within their immediate sphere of influence, for example, with members or patients. At the community level, we suggested that organizations work with others within their community to make a community-wide impact. And at the systemic level, we suggest they look at the root causes and look for ways to address those root causes that foster health disparities and inequity. You know, when I began at UCare in I have to think about what year we're in, 2018, it became apparent to me that UCare needed to evolve, not just because of the economic, competitive, and regulatory pressures that I referenced earlier. I probably shouldn't use the word pressure because it sounds like something that isn't good, but in essence, impetus probably, or imperative is maybe a better term. So the economic, regulatory, and competitive imperative to change. But I also recognize that we needed to evolve um, for the sole reason that we needed to do things differently to serve our members differently. And one area we needed to involve in was addressing the mental health and substance use disorder conditions for our members. Even before the pandemic, the prevalence of those conditions was high, particularly in our membership. but there was difficult access, poor access oftentimes to care, and systems were difficult to navigate. If you look here in Minnesota and across the country, there is poor access to mental health and substance use disorder services overall, and even worse, access to people from diverse communities. Further, I knew from my clinical practice that if UCare didn't do more or evolve how we addressed our members' mental health and substance use disorder issues, there was little else we could do for them. So we decided to act at the individual level, so within our sphere of influence, and develop a Department of Mental Health and Substance Use Disorder Services. It's now called Mental Health, Substance Use Disorder Services, and Special Need Basic Care. That's why we call it MSS for short. Anyways, we developed a department in my division which implemented a variety of initiatives, again, acting at the individual level, including implementing a triage and access line so that members, their families, their providers could call UCare and get help getting care, and whether it was needed immediately or sometime into the future. Now, acting at the community level, our Mental Health and Substance Use Disorder Services Department convenes a key advisor group. And this key advisor group consists of experts in the field of mental health and substance use disorder services, community members, interested family members. And that group informs our work at UCare, but also helps us galvanize action beyond UCare. And finally, thinking about our work in this example at the systemic level, UCare, even before I got there, advocated for peer mental health services to be a covered Medicaid benefit. And this occurred actually in 2009. And UCare also funded the training and certification of people to become peer educators, because certification is required for those services to be covered by Medicaid. Now, this framework, moving on to population health, this framework guides our population health activities. UCare members are at the center, and advancing health and racial equity surrounds all of our population health activities. Let me just go back and say that when we look at all of our anti-racism work, one key area for us is advancing health and racial equity for our members. And we do that within the framework of population health. So this framework has 5 major linked components: data collection, population health assessment, segmentation and stratification, member-centered initiatives, and quality measurement. Additionally, the arrows indicate the continuous improvement cycle that is built into the framework. And the framework occurs within an environment of advancing health and racial equity. You know, it's funny when you put these graphics together, there's lots of debate about where the different pieces have to go. And we initially thought we would have health and racial equity as a foundational component to the whole framework. But folks said that looks like it's at the bottom. So let's describe our work and think of our work in population health as occurring within an environment of advancing health and racial equity. Anyways, we know that to advance health and racial equity, we must identify the health disparities affecting UCare members. So to do this, we regularly conduct a population assessment to examine characteristics and needs of members, as well as of subpopulations of members. And this assessment includes a multidimensional analysis of member demographic data, including race, language, gender, age, eligibility group, household size, disability status, and attributed care system. Diagnoses, chronic conditions, utilization patterns, and social drivers of health are then examined within these demographic subgroups. And the results of this assessment, including disparities in health outcomes across populations and subpopulations, are then used to create or refine existing programs and match members to appropriate programs. It's hard for me to even describe that in a short period of time, which is why we developed a Department of Population Health, which includes health services analytics function that partners with UCare's healthcare economics team to drive the analysis, the data and analytics work, so that there's information that can go to various areas as they look to develop initiatives to improve outcomes. So let me give you an example of how this works. At UCare, we studied the impact of COVID-19 on our membership, and we examined factors associated with both testing positive for COVID-19 and for testing positive and having an associated hospitalization. And we use that hospitalization as a marker of more severe disease. Our analysis found, as we now, and this analysis was done early in the pandemic, and now, of course, there's lots of data that shows this. We found a disproportionate impact on our Black and foreign-speaking members. And we use those findings to direct UCare outreach at the community and individual level. And for example, we partnered with 2 pharmacies, Banadir, which is in the Lynn Lake community in Minneapolis, and the Juba Pharmacy, which is in Ventura Village, in the Ventura Village community in Minneapolis. And those pharmacies serve a high number of our Somali members. And we worked with that pharmacy to distribute masks and hand sanitizers with prescription deliveries. We're so thankful to those pharmacies for partnering with us, and we're thankful for the work that they do with UCare members. UCare also distributed 2,000 disposable masks and hand sanitizers at Juba, and 1,500 disposable masks and hand sanitizers, as well as a variety of pill boxes at Banadir. And our work with pharmacy continues, both with community pharmacies and retail pharmacy chains. But we've done so much more related to COVID-19, as has a lot of healthcare organizations. But I just wanted to highlight that as an example of how we've used a population health approach to tailor our initiatives. Let me give you one other quick example. And this is, again, from our population health program. And that's our work to promote healthy pregnancy and postpartum care. And again, tailor our work to the needs of our members. And so we looked at data and found that we needed to do more for our Black women who were pregnant and partnering that were part of our membership. So we partnered with the African American Babies Coalition. And that was because we looked for, with this analysis, where we needed to focus our efforts. So again, we look for racial and ethnic disparities in quality measures and implement strategies to address them. I'm going to skip the next example, but let me just say that we have partnered with community health organizations because they are closest, they're often of the communities that UCare serves, and they're better able to work on behalf of UCare with members to ensure that members get the care that they need, most importantly, preventive health services. You know, I like to believe that we would have taken a population health approach and addressed the social drivers within a framework of advancing health and racial equity. And as a company, we would have committed to anti-racism, even though there are competitive, that we would have done it even without, rather, the competitive and regulatory reasons to do so. But those are significant imperatives, and they are instrumental in driving our work. You know, I remember back to when I worked at Hennepin County Medical Center, now Hennepin Healthcare System. Even back then, health plans were using this kind of framework to think about their members in new ways and to partner in new ways around initiatives. So I remember Glenn Andis, who at that time was an executive vice president at Medica, coming to us at Hennepin and saying they were seeing a lot of their pediatric members getting care in children's emergency room, or and needing to be hospitalized at children's, but primarily getting care within the emergency room at children's, because there wasn't after hours care in the vicinity of where those pediatric members lived. And so what we developed at Hennepin was an after hours pediatric clinic to serve, all pediatric patients, but at the suggestion of Medica. Let me move on to UCare's diversity, equity, and inclusion work. Oops. UCare is working internally to develop an anti-racism approach, as I mentioned. And as part of it, we have an equity and inclusion department that is responsible for implementing a multi-year strategy to equip staff, leaders, and those who govern UCare, as well as our advisory committee members, with skills to make equity and inclusion decisions. So the framework is based on this Bringing Light and Heat framework that is called Bringing Light and Heat, a health equity guide for healthcare transformation and accountability. And you might find this framework helpful in your work or that of your organization, because it really includes a lot of support and information about how you develop, implement, and sustain strategies to advance equity. The Bringing Light component includes 5 steps that follow a structured process to achieve system transformation, and those are commit, build capacity, assess and strategize, change practice and policy, and learn. Whereas the Bringing the Heat component includes steps that are meant to ensure that there is organizational accountability for health equity. So those steps are governance, transparency and answerability, compliance, and consequences. And so here's a high-level view of where we are in terms of the Bringing the Light component of our equity and inclusion roadmap. I won't go through all of these pieces because I don't have enough time, but I just want to highlight that I'm particularly impressed with the plan to co-create initiatives and progress measures with members and other stakeholders, because we committed as a company to incorporating member and community feedback in all levels of our work and ask ourselves, who is included or excluded from this conversation and why? And how do we plan on engaging populations experiencing health inequities in the co-creation of our work? We're also critically examining our policies, procedures, and practices within a health and racial equity lens. In fact, we piloted the use of a health and racial equity assessment tool to assess the health and racial equity implications of our programs and processes. And we based our tool on a number of different similar tools, including one that the Minnesota Department of Human Services had used itself. So various UCare departments have used the tool to assess their areas. Well, thank you for your attention. The impact of racism on health is profound and has been known for decades, for a century, over a century. There are approaches such as using a population health framework through equity and inclusion initiatives to better serve individuals, families, communities, and to dismantle systemic and structural racism. I hope you can see, I know all of you know, because this is work that most of you are probably involved with, that the financial cost of failing to change healthcare this way is substantial. But true sustained change after this moment has passed will come when we attend to the moral law within and do what is right, even if it's hard for us and for our organizations. So I've left some time and I look forward to comments and questions. Thank you.
Dr. Julia, that was excellent. Thank you so much. I want to thank you. In addition, I also want to thank the Center for Anti-Racism Research for Health Equity. led by the founding director, Dr. Rachel Hardiman, in helping us get the word out about your seminar, Dr. Julia. A lot of you attendees would not have known about this had it not been for the center. So I appreciate the collaboration with my friend and colleague, Dr. Hardiman. So Dr. Hardiman, we're going to start off with you with the first question.
Sure, I'd be happy to. Thanks again for allowing us to participate. This is great, Dr. Julia. It's been a while since I've had a chance to hear you speak, so it's always a treat.
Oh, thank you. And it's funny, Dr. Hardiman and I will like see each other in these random sort of events, like a national thing we're involved with, and there we both are.
Yes, that's exactly, and especially over the past couple of years in our little boxes. So I really appreciate your discussion on the population health approach and the data-driven approach that you all are taking at UCare to create these opportunities to build on health and racial equity. And as someone, personally is very focused on the data and how we use that data for action, and particularly thinking about how we measure structural racism and other forms of racism, I'm wondering if there's data elements that you see as being needed as that population health approach is moving forward. Like, are there any gaps and things that you're saying, I wish we could capture this because it would help us to understand how we want to move in a certain direction? Is there anything missing? And, particularly for me, coming from a health services research lens, like what could that, how can we help support that work? Because I think it's a really innovative and important approach from a payer, right, to be able to leverage data in that way to towards health equity.
Yes, thanks for that question, Dr. Hardiman. When I think about your recent paper around measurement and structural racism, I don't see any gaps in what, as you're thinking about how to measure, I think, structural racism. And I believe you're also looking at measurement as a way to understand whether different initiatives are working or not working. Yeah. I believe that's what you're doing. So that'll be terribly helpful for a healthcare organization like UCare. I shy away from the need to understand what has traditionally been or to say we need to understand whether there's a return on investment when you put an initiative in place, let's say to address racism, whether at the systemic or structural level, because that's too narrow a focus. One of the first things I learned when I got to UCare, when I looked within UCare and externally at our competitors, our regulators, what the financial imperatives, was that it wasn't sufficient just simply to reduce costs or demonstrate affordability or cost effectiveness, that we had to have a value approach. So if we only look at things through a return on investment, that implies a financial return, and value involves so much more. I always jokingly say that health plans, this is why we're highly regulated. This is Dr. Julia's view on the world. This is why we're highly regulated, that we've demonstrated we can be cost effective. But if we want to demonstrate value, we have to look more broadly. And we use value, we use the quadruple, now the quintuple aim, as some people are referring to it. We use those aims as how we demonstrate value. So I would say we don't need more on the ROI, but perhaps more on how addressing structural racism, how we can demonstrate that we are truly addressing structural racism. So the work that you're doing, and perhaps a link to value. I think that would be helpful.
Dr. Julia, the next question comes from Dr. Jim Hart. So I want to introduce the topic. For those of you who are unfamiliar, when we use the term governmental public health agencies, we're referring to city health departments, county health departments, and to some degree also our partners at the Minnesota State Health Department. So Dr. Hart asks, many of the activities you describe sound like the work of governmental public health agencies. Why not leave the money with these agencies and allow them to do their traditional work for these defined geographic areas?
Oh, that's an interesting question. I don't think I can comment on the state's decision about, the allocation of resources. But what I can say is that our partnership with county and public health has always been an important part of how UCare works successfully with members. Um, I was talking to Ramsey County and St. Paul Public Health recently to better understand their work they're doing in Ramsey County and St. Paul, and we've done that across the state. So I maybe can't speak to the allocation that the legislature or the state decides on in terms of whether money goes to the counties and public health organizations, but I can say that county and public health are key partners to UCare.
The next question comes from a former student of ours, Chelsea Jorgensen. And so she's wondering if you could speak more about your thoughts on social drivers of health, particularly entities that we have not traditionally considered as partners in these areas. So for example, banks and lenders are key players in housing access, but I'm not sure, she writes, we've traditionally considered them as key partners in healthcare initiatives. Mm-hmm. What are your thoughts about incorporating them, Dr. Julie?
Thanks, Dr. Wynn, and thanks, Chelsea, for that question. We're at the, I would say, early stages of thinking about that. As I referenced in my last response, the way I think about it is, and I hear some folks will say, well, UCare needs to spend its money. It's not UCare's money, okay? This is the citizens' money, the members' money who have bought premiums. So use the resources that are entrusted to us the most wisely. And I think what Chelsea's referring to is what we're starting to think about is how do we ensure that the banks, for example, that UCare is involved with, that they are doing what they need to do to address the root causes of social drivers and address the social drivers that are, driving these inequities. So I think it's an important piece, and it's one that we began in 2020 to consider at UCare.
The next question will actually be asked by the questioners. So Kavita, could you unmute and ask your question? Oh, you just wrote to me and said you'd like me
to. I can do it. So I'm a pediatric pain psychologist, and I was just curious about the sickle cell population. So when I think about health equity and systematic racism, Black youth have the burden of a lot of negative implicit bias. And there's been studies that show that in ERs, Black youth get lower pain medications than a white youth would for the same injury. Thinking about sickle cell particularly and the substance abuse crisis, I'm just curious about how or if there are specific programs through UCare or just through Minnesota State that are addressing specific populations that tend to be frequent users because of the illness itself.
Thank you for that question, Kavita. I wish I could say that at UCare, our population health framework includes a better understanding of those disparities, not only within groups, but also within certain disease states. We're still early in looking for those disparities. So for example, for our members who have diabetes, COPD, congestive heart failure, those kinds of things. But I wholeheartedly endorse looking for disparities, including in treatment, and then partnering with providers to let them know what we're seeing, because UCare with our data has a very broad view, and encouraging them to change their practice. We are embarking more in value-based arrangements, for example, in oncology care. And as part of those arrangements, including components of advancing equity in those contracts with providers. And I would see the same as being effective around sickle cell disease treatment.
So Dr. Julia, this brings us to the end of our time, but I want to thank you on behalf of the group for your efforts, your leadership, and absolutely your seminar today. If anything, I'd like to open the door up for more conversation and discussion on these important topics. And you are welcome back here at the School of Public Health at any time. And we look forward to having you come back. So thank you so much, Dr. Julia.
You're welcome. Thank you, Dr. Nguyen and Dr. Hardiman, and everyone in attendance for listening.
Thank you. Goodbye, everyone.
Bye-bye.
Bye-bye.